I am myself Dr. Mamatha T.R, Assistant Professor from General Medicine Department from ESI Medical College, Rajajinagar, affiliated to Rajiv Gandhi University of Health Sciences from Bangalore, India. My topic is acute ischemic stroke in COVID-19. Acute ischemic stroke in brain is also emerging as an important neurovascular or neurological complication of COVID-19, which is associated with extreme immune responses leading to dysregulated coagulation system and generalized thromboembolic status, which leads to increased risk of acute ischemic stroke. We had a case 65 years old female presented to us with chief complaints of right-sided weakness of upper limb and lower limb since 4 days, which was sudden in onset, progressive in nature, and attained maximum weakness on the first day. She also has a history of loss of speech since 4 days. And the patient was able to comprehend, but she was not able to speak. And there was no history suggestive of cranial nerve involvement, no history suggestive of sensory involvement and cerebellar involvement, and there's no history of bowel and bladder disturbances. Patients also gives history of fever since 3 days, which was intermittent in nature, high grade, associated with chills and rigors, which was subsided by taking medications. Patient also had a dry cough since 2 days, not associated with breathlessness and chest pain. And patient was not a known case of hypertensive or diabetic disease or cardiac disease. And there was no past history of transient ischemic attack or stroke. On examination, patient was conscious and she was obeying to commands. Her pulse rate was 110 beats per minute. Blood pressure was 130 by 80 mmHg. Respiratory rate was 28 breaths per minute. Temperature was 100 degree Fahrenheit. Oxygen saturation was 92% in room air. Coming to the CNS examination, patient had motor aphasia, hypertonia of right upper and lower limb. According to the Medical Research Council, power of right upper limb and lower limb was 2 by 5. Superficial reflexes was absent. Right plantar reflex was extensor. Left plantar reflex was flexor. The other system examination, that is central nervous system examination, sensory system was normal. Cerebellar system and gait could not assess. The skull and spine was normal. There was no signs of meningeal irritation, and other systemic examination was normal. Investigations, since the patient had a saturation low, we did ABG, that is arterial bed gas analysis, which was suggestive of type 1 respiratory failure. Blood investigations revealed hemoglobin 12.6 gram percent. Total count was 8,060. We found a predominant neutrophils, that is 79%. Lymphocytes was 12%. Neutrophil lymphocyte ratio, that is NLR ratio, was 1.01. Renal function test and renal liver function test was normal. Glycosylated hemoglobin was 6.1%. Random blood sugar was 156 milligram per dl. Serum LDH was 127 international units per liter. D-dimer was 4.8. Serum CRP, that is C-reactive protein, was 27 milligram per dl. And serum ferritin was 39.7 micrograms per liter. Interleukin 6 was 0.018 picogram per ml. ECG showed a sinus tachycardia. Chest X-ray was suggestive of bilateral lower and mid-zone infiltrates. Predominantly infiltrates was seen in periphery. RT-PCR for SARS-CoV-2, that is for COVID-19, the swab was positive. And since the patient had weakness of the lower limbs, upper and lower limb, we did a CT brain plane, revealed left inferofrontal and parieto-occipital infarct. So this chest X-ray shows bilateral, lower zone, and even the mid zone infiltrates. Predominantly, we can see peripheral infiltrates. This section shows plain CT brain showing left inferofrontal and parieto-occipital infarct. Here also you can see showing left inferofrontal and parieto-occipital infarct. This section shows plain CT brain showing left frontoparietal infarct. Frontoparietal infarct. So with all this history, systemic examination and investigation, we diagnosed the patient had right-sided hemiparesis with left ischemic stroke with COVID-19 pneumonia. And the patient was confirmed SARS-CoV-2 and saturation was on the lower side. We started the patient with oxygen 4 liters per minute, injection mannitol 100 ml 3 times daily, injection ceftriaxone 1 gram IV 2 times a day, injection dexona 6 mg IV once a day, injection pantop 40 mg IV twice a day, and anticoagulant injection enoxaparin 40 mg subcutaneous twice a day, followed by tab ecosprin 150 mg once a day, tab atorvastatin 40 mg once a day. And after starting all these medications with oxygen, we noticed the power of right-sided upper and lower limb gradually improve over a period of 10 days, and room air saturation improved to 95%. And finally, the patient was discharged with clinical improvement. So, COVID-19 is a current worldwide pandemic with multiple complications. Studies have shown multiple neurological manifestations, including cerebrovascular accidents in patients with severe infection. So, the current understanding of COVID-19 pathogenesis includes inflammation, endothelial dysfunction, and coagulopathy, which appears to play a critical role in COVID-19 associated cerebrovascular diseases. So, by this, we'll come to know that inflammatory process of SARS-CoV-2 have a fundamental roles in etiology and pathophysiology of the stroke, and the presence of COVID-19 infection itself could be a factor in the genesis or worsening of the stroke, in addition to the potential risk of cardioembolic stroke due to angiotensin converting enzyme 2 expression in the heart and the subsequent cardiac dysfunction. This slide shows the potential pathophysiological mechanisms for stroke in COVID-19. As I said earlier, the first is the inflammation. The SARS-CoV-2 binds to the ACE receptors in the lung and other tissues, including endothelium, and it activates the immune system, resulting in the release of cytokines. So this subsequently leads to neutrophil recruitment and release of tissue factor. And then secondly, coagulopathy, that is inflammation induced release of tissue factor, binds to the factor 7 and activating the coagulation pathway. So elevated D dimer is a marker of shutdown of fibrinolytic system, and the net result is propensity to form thrombus. The third mechanism is endotheliopathy, that is binding of endothelial ACE2 receptors leads to direct cytotoxic effects. So cytokine storm leads to endothelial release of von Willebrand factor and platelet activation. So all this inflammation may induce plaque vulnerability to rupture. The fourth mechanism is the platelet activation. So here the platelets play an important role in the thrombus formation in COVID-19, releasing chemokines that attracts inflammatory cell. So fifth is the cardioembolism. About 20% of the hospitalized COVID-19 patients suffer cardiac injury, which can lead to arrhythmia and act as a direct source of cerebral emboli. So all these mechanisms plays an important role in COVID-19 patients to leading to complications of neurological complications, most commonly the acute ischemic stroke. Higher rates of strokes have been observed in patients with coronavirus disease, it is COVID-19. Large vessel stroke has been reported as the presenting features of COVID-19 in the in patients. Coming to discussion of our case, even though respiratory symptoms predominantly seen in COVID-19 patients, our patient presented with weakness of right upper limb and lower limb as a chief complaint, and her CRP and D dimer was elevated. So this indicates that the SARS-CoV-2 has increased affinity towards the ACE2 receptors, which are expressed in the endothelium and arterial smooth muscle cells in the brain, resulting in inflammatory process, endothelial dysfunction, and prothrombotic state causing acute ischemic stroke in our patient. Conclusion. So, COVID-19 infection can be the independent risk factor for developing acute ischemic stroke due to its prothrombotic state. And those patients with neurological manifestations should be evaluated early, and diagnostic workup and timely treatment should be done to prevent morbidity and mortality. These are the references. Thank you.